We've begun. Hello, everybody. Thank you so much for coming. We're going to be starting the webinar and bringing on our first speaker in about 3 minutes. I'm one of your hosts. I'm 𝗲𝗲𝗀𝗲𝗏. And I'm joined, sorry, I'm tripping over each other. I'm joined by 𝗏𝗏𝗀𝗀𝗏𝗏.
Hi, good afternoon, everyone. My name's 𝗏𝗏𝗀𝗀𝗏𝗏, and I'm your co-host for this webinar as well. So thank you for having me.
You know, we were actually a bit surprised by the people who registered for the event, and because there's a lot of people who are not in oncology at all. There's actually a lot of people from tech companies. And I think, I haven't actually asked them why, but I suspect it's specifically because what's happening in oncology with AI, there's a lot of people even outside of oncology that are kind of like on the other side of the glass looking in at these use cases, because it's very innovative. And a lot of people kind of have the impression, and I share this, maybe you do too, 𝗏𝗏𝗀𝗏𝗏𝗏, that what's kind of happening in oncology now is going to kind of roll out. I mean, not necessarily the same solution, but something similar will roll out to other fields of medicine. That's one. And the other thing too is, I think the last year and the health AI conversation was very kind of general and almost a bit abstracted. And now people want to go into use cases, even other people's use cases, to understand.
Yeah, I love that, Jose. It's exactly right. I mean, oncology has always been a really exciting space because we can provide so much value to patients. This is such a devastating disease. And AI totally disrupts that when we think about early drug discovery and early disease discovery and pathways in which AI really changes the space and navigates how we treat patients. So oncology absolutely is an excellent use case for potentially how tech can transform the landscape of treatment and diagnosis. And I really look forward to hearing from our panelists very shortly.
You know, I think it's also, and I've spoken to a few oncologists, they're excited, and they're saying, well, we need to be patient and give the technology room to grow. But there's also this understanding that pure Gen AI isn't quite there. There's limitations. You can't just go.
Yeah, you know what it is, Jose? I feel like because we're talking about patients here and such an important broad range of diseases that, you know, oncology covers so much space, you really want to let the industry mature before you bring it to a patient. So having visibility around how we've designed some of these models, what that entails, what the governance of those have been, where we've responsibly innovated, in bringing that to the conversation with clinicians is equally as important when we're talking about such an important disease area.
Okay. I think we're ready to bring on our first speaker.
I'm excited. Let's do it.
Okay. I actually posted and if anyone follows me on LinkedIn, our first speaker is Jessica. And good morning, Jessica. I think it's really early where you are, maybe. And thank you for coming. And I know it was a bit difficult. You were traveling and all these things are going on, but you came, and I really appreciate that. And I've spoken to you before, and you're more on the drug discovery side. And
drug development, but yeah.
Oh, sorry, drug development. Sorry, drug discovery. Okay.
It's a big puzzle, right? Discovery and then development. So first we have to discover them. So, but yeah.
And Jessica is going to set the table for us. And should I be introducing you more fully? I've just said, I've kind of labeled you wrong. Is there anything else you want to say by way of introduction?
No, I mean, I'm just Dr. 𝗲𝗲𝘀𝗀𝗏. I'm the Chief Medical Officer at Oncoscope-AI and a drug developer for many, many years. So really excited to join and be a part of this discussion today.
And just for the first question, can we be a bit multivalent? Because keep in mind, there's people in the audience who are not that familiar with oncology. And we're not going to and can we talk a little bit about what's kind of like the opportunity and the challenge with all the research data and why that matters?
Sure. So, you know, I've been in oncology for over 25 years, developing drugs and, you know, even testing in animal models. The challenge that we have with oncology, it's a challenge and an opportunity, right? The challenge is we have so much data coming at us. There's so many new drugs. There's so many new markers or something that's considered important for your disease. And we call them like biomarkers. And all of that information is just coming in on a daily basis, almost in some capacities. And it's really hard to stay on top of all that data. There's, you know, even a person that has spent my entire career in the space, I am always behind in this space, even though when I think I'm doing the best I possibly can. And so when I think about, you know, I will work in a narrow lane, let's say, like breast cancer, we're talking about today. But when you think about all those physicians out there, they're dealing with patients that one breast cancer, one lung cancer, one prostate cancer. So if we think about just the amounts of data coming in at breast cancer on a daily basis, then you add in all the other cancer types, because every organ can have a cancer, it's almost impossible to know the newest and or even the most current with regards to how best to manage your patients. And so this is why I get super excited about how, you know, we're talking about AI being a complementary tool for how we can best help the patients. And so as a drug developer, I see this as an excellent tool. In all the years that I've been working with the physicians that I work with, I think we're really starting to kind of crack the nut to be able to kind of give them an unbiased amount of information, put in a nice package so they can spend the time to really understand what they need, that information for their particular patient.
Colin, did you have a follow-up question?
Yeah, no, and I agree with you, Jessica, sorry. I wondered if, in your experience, where have you found the roadblocks around clinicians really adopting that sense of using AI to actually streamline some of the drug development, some of the trial development that they might want to do, an idea that they have, actually using tools that are available? What are some of the challenges that you've come across around implementing and actually getting that absorbed into workflows and patterns of thinking? I imagine there's probably been a couple. So before we talk about solutions, it would be great to sort of map that out with you.
Yeah, I think the biggest thing is, you know, in this, I would say the past 5 years, AI has been the big word, right? But just because we're saying AI doesn't mean we're getting rid of the human portion of it. I think we still need, because this is such a complex arena, it's not like when you treat a breast cancer patient, you're looking at the exact same things as when you treat a lung cancer patient versus when you treat a prostate cancer patient. So there still needs to be kind of a humanistic check, if you were to say, because AI is a fantastic tool that you can continue to learn from And again, I'm definitely not an expert within AI. But that being said, I think the problem, back to your question, the problem is it's kind of the trust, because it's something new. Is it taking away that critical thinking ability that physicians have to do because they're looking at their holistic patient? And so that's where I can see the challenge is kind of the scarcity of it being so, I would say, still new. What we're used to AI, I would say, in the cancer arena versus where what Oncoscope-AI is doing, we're used to taking large data sets and identifying new proteins, and then we go and try to test those in the clinic. Well, that's just kind of a consolidation, if you think about it, tool, where what we're doing is not only kind of pulling in all of that data, keeping it unbiased, but also showing it in a view that's easily digestible.
Right. And sometimes the way I think about it is any tumor board I've been to, it's multiple types of professionals, right? You take an opinion from everybody, you come to a consensus. No one person is right. Everybody's got a view based upon their specialty. And AI is potentially your partner in that journey. It's another tool in your multidisciplinary team. We call them MDTs here in the UK. I think you call them tumor boards on the other side of the Atlantic. So it's like AI is your partner in that journey. Of course, it can never be the totalitarian view. I wondered what the solutions around that were and how much education and actually the foundational model and how that's been formed, that needs to be upskilled and educated to clinicians who might not think that they need that education, and how you potentially address that.
I think the best solution is we all have to be open-minded and know our own limitations. I think when I started this conversation, I said, how can anyone keep up with so much information, particularly if you're treating multiple disease types within your clinic? But even when I think about it just in breast cancer, with all the new information that's coming out, it's really hard to stay on top of everything. And so to me, embracing it as the best kind of way I'm looking at it as, it's another team member. We just don't see that team member, right? When you're thinking about, you have a radiologist at the table, you have your surgical oncologist at the table, and then you might have your oncologist or helping to treat from a therapeutic standpoint. This is just another tool at the table to make sure you've looked at all of the information out there to best suit the patient at hand.
I completely agree with you on that. And I think it's that reframing or that shifting. And when we're in a landscape where there's uncertainty around the future and so much noise in the space, sometimes we forget that ultimately, even today in the humanistic world that we deliver care, no one person makes an ultimate decision. It's always a group or a team. And so you've got an additional team member to join you on that journey, which is a gift. Is that how you implement it today? And do you have any examples of that?
So, I mean, how the best way to start to implement it within kind of how we're introducing it even today, and how we've been introducing it in some of the feeds is really to go in and look at the tool that we've created. This tool, it's a completely unbiased. We're helping as, again, another individual at the table that you just don't see, that provides all that relevant information for your particular patient at hand. So if you have a patient that you need to ensure that they have marker 1, 2, and 3, and you want to know all the available therapies out there and what perhaps is in the guidelines, then you put in 1, 2, and 3 marker, and then the tool provides you all the evidence behind there. It's not it helps aid in the best decisions for your patients. It doesn't do anything other than that.
Great. Thank you so much for your time, and we'll bring you back on at the end. Over to you, Jose. And you're muted, which means I have more airtime.
Thank you, Jessica. And I'm going to bring on Shanice.
Hi.
Thank you so much, Shanice. And I did an interview with Shanice. It was actually the first time I'd interviewed a patient advocate. And I learned a lot from you, Shanice, in that interview. And so thank you for that. And thank you for coming today.
Of course, it's an honor to be here, not just as a panelist, but as a wife, a mother of 3, and a survivor of triple-negative breast cancer. I am the founder of the Advocates Table, which that business derived out of my own cancer journey. And it is set up to educate, inform, and just help the community understand that we do have a voice and early detection does save lives. So triple negative breast cancer is one of the most aggressive subtypes, known for its rapid progression and limited treatment options. My journey with this disease began long before any symptoms appeared. It started with genetic testing for me. In 2020, after years of heavy menstrual cycles and a concerning family history of cancer, I underwent genetic screening. The results were life-altering. I learned that I carried both the BRCA2 as well as the PMS2 gene mutations, significantly increasing my risk for breast, ovarian, and other cancers. This crucial information led me to take proactive steps, including a full hysterectomy in 2022, and to enter a high-risk surveillance program that included regular breast MRIs. It was through one of those routine MRIs, not a mammogram, which had came back normal, that my cancer was discovered. I was diagnosed with stage 1, grade 3, triple-negative breast cancer, small in size, but aggressive in nature. Early detection guided by precision medicine made all the difference. So when we talk about precision medicine, what does it mean from a patient's perspective? For me, it's the ability to treat not just the disease, but the individual. It tailors care based on your unique genetics, biology, lifestyle, and environment. For me, it means having a roadmap informed by genetic profile, a plan that can take into account my specific risk factors and also allows my care team to act swiftly before the situation could escalate. But precision medicine isn't only about cutting edge tests and data. It's about using that information to create a care plan that truly sees you as a person. It's about the reassurance that comes from knowing your treatment strategy is designed specifically for you. I want to share a personal detail that underscores the profound impact of early detection and personalized care. When my cancer was discovered, my husband and I had to share that news with our children. That moment is seared in my memory, not only because it brought fear and uncertainty, but also because it highlighted how much every decision in our treatment journey affects our entire family. Being present for my family during such a difficult time depended on having access to the right care at the right time. This is the essence of patient-centered precision care. Accessible genetic testing, it should be a standard part of care, not an option for only a few. Timely advanced imaging, tools like routine MRIs for high-risk patients are lifesavers. Tailored treatment plans. Care must reflect the full context of a patient's life, including their family, emotional well-being, and personal story. Clear communication. Patients need to understand complex medical information in a compassionate, relatable way. On the technological side, innovations like AI have the potential to revolutionize how we deliver precision medicine. AI can sift through vast amounts of diverse, up-to-date scientific data, ensuring that oncologists have the very latest insights at their fingertips. This means quicker, more informed decisions, potentially matching patients with the right therapies or clinical trials more rapidly. But this technology must be built on inclusive data and, more importantly, be paired with genuine human connection. For those of us living through cancer treatment, every detail matters. I experienced chemotherapy in a way that many might not imagine. I wasn't in a standard infusion chair. I was in a bed to stay as comfortable as possible because of a reaction to one of the medications extended my infusion time far beyond what was normal. This wasn't just a technical detail, it was part of my story and reminder that patient care must always be adaptable and empathetic. My hope is that every advancement, whether in precision medicine or AI, is applied with one clear aim: to treat the whole person, not just the disease. When oncologists have access to robust real-time data like that offered by Oncoscope-AI, they are better equipped to tailor treatments that respect the nuances of each patient's journey. Yet, these innovations can only succeed if they're accessible to all patients, not just those in well-resourced areas. In sharing my story today, I want to emphasize that innovations in healthcare must close gaps, not widen them. They must prioritize patients' dignity and ensure that every individual, regardless of background or circumstance, receives care that is as compassionate as it is precise. So my call to action is simple. To researchers, build clinical studies and models that truly represent populations. To clinicians, continue to listen, empathize, and treat each patient as an individual with a unique story. To tech innovators, design AI systems that support and do not replace the irreplaceable human connection in medicine. To policymakers and administrators, work to make genetic testing, advanced imaging, and precision treatments available to all, regardless of socioeconomic barriers. Because in the end, our lives, our families, our futures depend on it. Early detection, personalized treatment, and compassionate care are not just scientific goals, they're human necessities. My husband and I, along with our children, know all too well how every decision ripples through our lives. And that's why I stand here today urging that we build a system that truly has the patient at its heart.
That's really powerful. Thank you so much, Shanice, for sharing that. And you know, I'm kind of blown away. I don't know what to say. Sorry.
Well, I think what Shanice, my takeaway from that is really it's that stark reminder that the patient really is at the heart of this, and I really took that away from what you've just said. From your perspective, with a patient, so you've been a patient. Thank you for sharing your journey, but you're also across a network of patients, perhaps past, current, and future even. So, what do you see as the roadblocks around patients incorporating AI into some of the pathways around precision medicine? Do you see there be any roadblocks to that? Is that something that we can discuss, help navigate? Have you had those sorts of discussions where you've benefited perhaps from that precision medicine approach, but perhaps there's a lack of awareness perhaps in certain cohorts? So what has been your experience around that?
So I do believe a lack of awareness. Many people, or patients, when they are going through this cancer journey, are really just focused on, how fast can I get well? Am I going to get well? And, how I navigate that. Many patients don't really take the time to go and do a lot of the research, just dependent on their situation and circumstance. And I feel like with AI being the new, thing in technology.
Buzzword, right? Yeah.
Yeah, the doctors sharing that information and also allowing the patient to ask questions about it if it's going to be utilized can help build some trust. That's the first thing. Having trust with your medical team and knowing that they care about you and are empathetic to your situation, not that you're just another patient that they have to treat and then rush off and go into another room. Taking that time when you're sitting in there with your patient, really getting to know them, their circumstances, and helping them understand that this is going to be something that can possibly help them. And in my situation, as having genetic mutations and having triple negative breast cancer, did the treatment plan that I was offered, would it have been something different if AI was utilized? If the system was trained well enough to know how triple negative breast cancer interacts with the genetic mutations that I have, so that the treatment that I was given was just for me, right? And my situation.
Absolutely. Yeah.
Because it's so hard to treat, this isn't for me, it was like throw spaghetti at the wall and see if it sticks, right? Because there is no one size fits all treatment plan for triple negative breast cancer. It's one of the hardest to treat. So I was severely lucky that I caught my cancer early, but that was only due to me having genetic testing in advance of it, not when the cancer was caught. So
Yeah.
I think that it's very important to really understand that fact as well when we're explaining, or when oncologists are explaining different measures to how their cancer can be treated.
It's even
we're gonna have to move on, Oncology.
Sorry, thank you. No, well, we'll pick
Rude.
the conversation up at the
We're
end.
bringing Shanice back at the end. Thank you so much, Shanice. Don't go anywhere, please. We're gonna bring you back. Hello, Mayron. Thank you so much for coming. Actually, I think you were the first oncologist I ever spoke to over Zoom.
Great.
And I learned a lot from you. And Mayron is a oncologist surgeon focused on breast cancer. Is that correct?
That's correct.
And you know what, I want to pick up what you said to me when I met you. You said it's a new technology. It needs to be given room to grow. And you also said you had some criticism, but you didn't actually go into the criticisms in that call. But I'm not to be poo-pooing it, but I'm wondering if you can talk about some of the challenges, the room for improvement, where it's not quite there yet, where you're sitting.
Thank you so much for the opportunity. Hello, everyone. I am a very, very big proponent of AI in medicine. As a breast cancer surgeon, researcher, and overall as an oncologist, so we deal every day with the decisions that are not only medically complex but also deeply personal. From interpreting imaging to weighing molecular profiles and surgical goals. Our mission is always the same: to deliver the most precise, personalized care possible. That's exactly where I see the transformative potential for AI. In the preoperative setting, AI can analyze imaging amazingly and pathology data to starting from the screening, the diagnosis, as well as in the operating room into the potentially the enhancing margin assessment and predicting nodal involvements. These are all potentials that AI can really transform the work, helping us tailor the surgical plan with greater clarity. During surgery, potentially, AI guiding imaging may soon allow real-time identification of tumor margins or residual disease and potentially reducing the re-excision rates. And in the postoperative phase, AI can help predict complications, personalized surveillance, and guide adjuvant therapies decision based on a holistic views of the patient data. So the potential are absolutely amazing. But for all this promise, we must also confront the limitations. One of the most critical areas for improvements is equity. As Shanice very elegantly mentioned, too many AI systems are trained on a non-representative data sets, which risk perpetuating disparities, especially for historically underserved population. If we are to harness the AI full potential in oncology, we need tools that are trained, validated, and refined with diverse patient population in mind. Ultimately, I believe in AI that is clinically trustworthy, explainable, and seamlessly integrated into our workflow, not to replace medical, surgical, or oncological judgments, but to extend it. The future lies in surgeon slash oncologist slash doctor informed AI built with technical brilliance and clinical nuance and rooted in equity. And that's where we can make the greatest leap forward in truly personalized breast cancer care, and in that sense, any other cancer care. Jose, you're muted.
I know. Sorry about that. Akanya, did you have a follow-up question?
Yes, and great to meet you, Dr. Habibi. Thank you so much. So, when it comes to the research side, and you know you're involved in research, how does AI disrupt that space? How do you see that evolving over the next 5 to 10 years?
It's absolutely incredibly. I think with the context of the AI advancement, AI agents in the clinical trial and clinical research, you can create essentially a virtual lab that can work very, very rapidly using the AI, databases and AI, kind of like infrastructure to rapidly advance the research. I think it is going to be completely revolutionizing the way that we do research. I'm very excited about that.
So then when that translates to the workflows and having a more patient-centric precision approach to each patient, are you looking at how that really translates to, at the moment, we have quite a broad brush approach to patients relatively, and tech is potentially going to change that. We know that there's a need for it, there's an appetite for it, we have patient advocacy around that. How are you bringing that to the actual workflows of delivering care where, you know, whilst hypothetically we know things are changing, actually the workflows when you're in front of the patient, when you're delivering your inpatient care, that's still challenging to get that innovation across. Have you found that slight mismatch or challenge?
Ask me in 2 weeks, ask me in 2 months. This is such an evolving field. You're absolutely right. Most of the research, most of the data it is all retrospective. Even when we do prospective, by the time that get published, the process is just so long. By the time that gets to the clinical, it's several years old. With this, it's going to change in a almost a real time fashion, and again, much more personalized than it was before. It is happening as we speak. These AI agents, these tools are just in their, I don't want to say in their infancy, but the whole thing is its infancy, is like less than 2 years old. This entire concept of the AI agents and the application of it in research is just beginning to shape.
I wonder, and I've watched some of your clips before, and I've heard some really interesting cases around how AI and tech has disrupted the way, or in a positive way, changed the way you deliver care to patients. I wonder if you could take us through a case story, an example like that, where it's ultimately benefited the patient, and we can understand how these hypothetical changes or cognitive challenges in our mind really translate to the patient at the end of the day.
Absolutely. A very simple, basically, application of it that is already in the use now is in the context of mammography and screening tools. So, I mean, we are lucky in America that you do have a lot of radiologists, you do have an access to the mammography and screening. A lot of other areas in the world really do not have those level of access, Now with the AI ability to be able to read mammographies using the machine learning principles built on millions of imaging that they trained on, and the outcome that they know of, now they can really help radiologists to read the mammographies much faster, much more efficient, and in times they can predict the presence and occurrence of a cancer 2 to 5 years before any imaging even show of evidence of a disease. It's a little bit of a mind-boggling concept, but those concepts is already available. Those tools already in in the use. And again, that's just one example of it. In regard to the drug discovery, it is going to revolutionize the access as well as the ability of the scientists to go through the process of this drug discovery much faster, much efficient. And again, you can take that and then go in every level of the care, from the diagnosis to the survivorship. It's going to revolutionize the care.
Absolutely. And I want to draw a comment from the audience. And sorry, we're not neglecting you. I just keep bringing up my own questions. So I wanted to draw on 𝗏𝗲𝗏𝗲. I hope I'm pronouncing that correctly.
Olivier.
Olivier. So he says, "Thank you, Mehran. I do agree. It is necessary to have more inclusion in future, and with regulatory bodies who want more and more real-world data, this is an opportunity to include data sets from all markets." So could you speak to that a little bit around?
So that's an absolutely great point. That's a great point. A lot of times, most of our data sets sits in the different silos. Surgical silos are different, pathologies are different. The hospitals have so many different silos. The countries have different silos. States have different silos. I think with this next step is to, if you can combine those, really use the leverage of this powerful tool, powerful machines to be able to use that. It is going to absolutely revolutionize. But that point is absolutely well taken. We need to break a lot of those silos and then incorporate all those data sets together. Not easy, but doable.
Doable. I mean, you use this term, I've written it down, rooted in equity. This is the mission that I feel I'm on with tech. It starts to level the playing field as long as that data is shared, it's clean, it's accurate, and it's available. So when it comes to data privacy and really the future and how much of our data is protected, how much of our data is actually viable and clean, how much does that form part of your thinking as a scientist, as a researcher? Are you interrogating the information within AI and what forms the foundation of the model as well? Is that a key question to you as a researcher?
There is no question about it. It is essentially integral part of our work. The data privacy and all that has to be. These are almost non-negotiable. Any company that's going to have any say in this space ought to follow the very strict guidelines, very strict data privacy and all that. Those are something that I think we have to essentially I think everybody agrees on, that those elements have to be very strictly followed, because without them, nothing is going to work. Yes, those elements have to be absolute, basic standards of the work. It is integral. The interesting part is that AI also can help with that, because when you're creating, for example, almost a virtual lab and AI agents, each specialized in one of the fields, you can actually have an AI agent with an ethical mind in basically as the core part of it, and he can actually checks and make sure that all those privacies and all that are kept very strictly. So to answer that question, absolutely a fundamental part of it, not negotiable.
Okay, and if I may steal one more minute.
Go on.
In a sort of your closing statement, Dr. Habibie, what is the one area that you are most excited about around AI and breast cancer and precision medicine in this space?
I think the application of it in research. I'm learning it as we speak, and it is going to completely change that we do research in breast cancer. It's going to revolutionize it.
Thank you, Mehran. We're going to bring you back in about 12 minutes. Thank you so much.
Thank you so much.
And I'm going to our final speaker. And hello, Anna.
Hello. Yes.
Thank you for coming. And Anna, I think it was a month ago. And I'm really impressed by your approach, because I speak to a lot of health AI founders. I know you don't like thinking of yourself as a health AI founder.
And one of the things that really impressed me is your anti-hype, and it's very engaged with the limitations of the technology and but how to work with that and find a way forward. And I wonder if you could, by the way, if you can introduce yourself, Anna. I know I've introduced you a little bit, but if you can do yourself maybe more fully.
Yeah. I'm Anna, and yes, I am a founder of Oncoscope, the company that is trying to help physicians with overwhelming amounts of data that we have every day. I am not a medical doctor, and I'm not an AI expert. I am a pharmacologist and a healthcare economist with a lot of years in drug development. That's how we met Jessica years ago, more than 10 now years ago. And I have done a lot of regulatory submissions on pharma behalf, as well as reimbursement submissions. And for these submissions, the main starting point was always, how do we gather all the data in unbiased way? Because everywhere in drug development, when you're starting with the drug, when you're creating your first protocol, you think of, well, I need to submit to the FDA and explain to the FDA what else is used in that specific population, and why am I choosing the endpoints I'm choosing, and how am I going to look versus these drugs? What is going to be my comparator? And the same thing goes in when the FDA submission, and a lot more goes in when we talk about reimbursement. So I would say I am an expert of that, gathering data and presenting and summarizing that. That is what I know, that I know how to do. I understand the sources, and I understand what do clinicians, in my case, mostly that work in regulatory agencies or pharmaceutical companies, how do they perceive that data? What do they need to see? But what I've realized recently is that, and I talked to a lot of physicians, and that's how it all started, is they're really overwhelmed by the information. And we talked today about AI potentially in various fields, how it could change oncology and breast cancer, from diagnostic to reading records and dealing with everyday overload, operational overload, to, I talked to physicians about, note taking and talking to patients. There's many applications, and there's no one magic button. I went to NCCN conference and they talk about, could it be a magic button and AI just fixes my life? That doesn't exist yet. But I thought I would use AI as a tool to address only one problem, very specific problem, which is too much information from various sources, from publications of clinical trials to the regulatory approvals and the guideline updates. I remember I spoke to a physician because I started this whole idea with, I'm just going to do a library and update that systematic review of the literature. And then the doctor, I still remember, he said, well, I still have to go to the guideline and I still have to check the FDA. Just bring that in. So I have been talking to the doctors since the first day I started, because the point is, I can only create the tool that is useful to them. With all my skills, I don't want to create something that is not useful to doctors. So I've realized that I understand how to gather the information, and I also see the downfalls of just the Gen AI type tools, ChatGPT and other tools that every day there's a new tool. We could just ask any question and it gives you the answer. The problem with these tools is the answer is often incomplete, mixed with partially wrong. And we're in oncology. We have a patient sitting in front of us. And if we don't have complete and exact, precise information, how can we practice precision medicines? Shanice mentioned, her cancer was diagnosed early. It's triple negative. If we don't know what's today the latest for triple negative with specific mutations, with BRCA mutations, with other mutations, what else for her patient's characteristics, there is information out there, but doctors do not have time to conduct a systematic literature review for every patient. And even in academic institutions where there's a lot of PhDs and residents, and you can ask them to do that for you, there's not enough time to keep up to date. So I thought, what if we use AI as the tool to help us in the process of systematically reviewing literature, guidelines, FDA approvals, and bringing it in the format that is easy for physicians to digest. And it is not a format of a beautifully written paragraph, which half of it tells you how great something is, which is what ChatGPT does. You know, the first paragraph you could skip, right? You don't need that. You need to get to the data. So we are very cut and dry. The tool provides you with tables and listings, okay, with the data. You enter patient's characteristics, metastatic stage, biomarker or genetics, you know, if there are any specific biomarkers, what have they been treated with? Did they have a surgery? Did they have a radiation already? Are you asking a question about specifically adjuvant therapy, or are you asking questions in metastatic setting and they have been on targeted therapy? These are all just, you know, every decision. I talked to a doctor today, actually, earlier, and every medical decision requires probably 5 to 6 questions that every physician knows when they have a patient in front of them. They know it's metastatic or not. Where did it metastasize? What are specific genetic mutations? And if you answer those, we're talking 5 clicks at max, you know, then what if you can get all that therapy, you know, in front of you? And if you want to know more, if you have the publications related to that, so it's not just the names of the drugs like ChatGPT would give you with the incomplete indications, right? It's not just that. We're talking about, you want to know more, you want to know which one of them reported benefit and overall survival, that's another click, okay? You want to know if any of them measured quality of life, and what are the specific side effects? Because sometimes maybe you need to choose from a drug that will cause GI severe side effects or neuropathic. I mean, unfortunately, that's how we're choosing. Do you want neuropathy or do you want diarrhea? This is horrible, but that is the daily life of when the patient is choosing. What can that patient tolerate? And ultimately, is there a choice that could delay the chemo? To me, that's the ultimate question. So that's where I am in the discussion.
Thank you, Anna. If I may ask a follow-up question, and that was really insightful. I mean, I've seen there are many examples in history of poor conclusions drawn from poorly gathered data, poorly designed data, poorly researched data, and ultimately, you know, the availability or the effort that someone's gone through to really understand the landscape before they've designed a research project. So how does Oncoscope-AI factor in the quality of research, which is also important to clinicians? It might be an N equals 100 scenario versus an N equals 10,000, and that might factor some of the decision making and recommendations that you make to patients. So how do you tackle that?
I'm actually so happy you asked that question, because this is a quintessential difference between Oncoscope and all the ChatGPT type, you know, open evidence and other tools that exist there. We conduct a systematic literature review following a protocol with a Cochrane method, which means we look at interventional clinical trials, prospective, well-conducted trials. We apply 4 different criteria on whether the publication is selected or rejected. We keep all the records of why it was rejected. So first, the decisions are not based on whatever is the latest and greatest on top on the internet, but it is based on what is based on the trial. And then we cross-link with the guideline, whether it is recommended by the guideline, it gets a tag, whether it is approved, it gets a tag, and whether it is a phase 2 or phase 3, category 1 guidelines or category 2. So there are some ways to recommend something when it has been recommended already by NCCN and ASCO and FDA. But on top of it, whether it is a phase 3 randomized trial, what is the number of patients in the trial? These are all things that go into the hierarchy of evidence when we look at that versus these other tools. Okay, I've seen them. I asked the same questions. I think I posted last week a very interesting experiment I've conducted. Sometimes the decisions are based on review paper, a case study, and you know, I haven't seen any reference of RCTs. RCTs are randomized control studies, for those who do not know. These are the golden standards for the regulatory approval. So why are we not doing the same for when we are making medical decisions? Yes, we sometimes go to non-randomized control studies, smaller studies, but we go there as hierarchical as the second choice when, let's say, the patient is in an environment where, you know, you're looking at the patient, it's a late stage patient with the specific mutation, and that patient already tried the targeted therapy for that mutation and unfortunately progressed. So the choice is, and the guideline says, please utilize clinical trial. You know, we've all seen that, right? So what happened to that patient? If that patient is somebody you know, or, you know, it is, you are the doctor. But for me, if that patient, somebody, you know, you don't want that patient to just get chemo. You want to know what else is out there, what else is in development that may have had a phase 2 positive trial, you know, and you may want to dig into that data. So, but you don't have the time to find that trial and dig. So somebody have done that for you. You will see, oh, there is a study that we categorize it as beyond guideline. You know, beyond guideline means there was a study positive. If it wasn't a positive study, it would say failed, and then you don't have to waste your time, you know, to read to the conclusion. But basically, I believe that it's our ability to check. And who checks that? It's between the system that we've created, where we have, I'm sorry to say, 37 models. And when I say that, people are like, yeah, it's simple. They are, because you can only utilize an AI. When a human knows the exact steps that need to be taken and the outcome that needs to come out, right? If you know, when you see the answer, you know, is it correct or is it wrong? Because you don't have time to go double check, right? So that's why we broke it all down in multiple steps, you know, and then we apply AI only to the steps when we know, and there's still steps we don't. And that's why we have a team of directors of research, and they check.
No, that's fabulous. It's sounding like, you know, any doctor who's been to a journal club or had a drug rep present to them, they love to interrogate the data. They love to, you know, really delve into, how did you design this study? Where could the holes have been? And AI is actually supporting them, as opposed to making that process opaque and just coming out with recommendations, which, you know, we're trained to actually think about it critically and appraise that to do best for our patients. So it sounds like, you know, this enables that, actually facilitates much of that critical appraisal.
Exactly. There's something to be said to writing a protocol and then following it in a scientific experiment. And that is why, you know, we post our protocol. Everybody can download and see that and go and repeat it. We treat this on the level of a regulatory submission. That's how we treat every search that is every day. It's assume this is what it is. So because of that, it's a different level of the quality of the data.
Okay, I think we're going to bring, and let's see if I can bring our speakers for final words. And I kind of feel like we can, there's a lot of comments and questions in the chat. I don't want anyone to feel neglected. We're going to follow up with everybody who's made a comment or a question. They will get a response. If you haven't had an answer during the event,
somebody will come out to you. Either one of the speakers will come out to you, approach you after the event, and I mean, we're not going to come to your house. We're going to message you and give you an answer. I appreciate that. We just don't have time to address all these questions. I wonder if we could do a final word. Shanice, can you start?
I would like to thank everyone again for having me here to share my story. And I just want to say that everything that everyone is doing is amazing. And I look forward to all of the progression of Oncoscope-AI and what will be utilized by the medical profession in the future.
Thank you. Jessica.
I guess my final words are, I think we should all be embracing AI and continuing to utilize it in every aspect. I think, as all of our speakers have spoke about today, AI is going to be a part of our lifestyle, and it's only going to make us do what we do better.
Thank you. Mehran.
Thank you so much for joining us. I learned a lot as well. I think we are going through a very exciting time in regard to research and clinical care in oncology, and utilizing AI. I think is gonna revolutionize our work.
Anna.
Well, I'm reading all the questions, and what I would like to say to those that are asking, is there an AI tool to do this or that? Please try Oncoscope. It's a tool, it's available, it's free. It will always be free if you are a healthcare professional. And to get it, you just go on our website, or you reach out to me directly. Happy to provide you access. We are in a beta version because we are receiving comments and constantly incorporating. It will be an iterative process, but I appreciate the more input I get from you, the better we can make the tool to help you solve the issues you have.
I'm going to put, have we put the website in the chat? I'm going to do that.
You can do that. It's Oncoscope.
Would you be able to do that? Let's see, I'm going to find it. I want to make sure I'm getting the right website.
Yeah, okay. Well, you added HTTPS to that. Yes.
Okay. Now,
yes,
Patanjali, we're all going to go away. And you
well, yeah, I mean, we in oncology, as clinicians and adjacent to the whole pathway that patients face in oncology, are so used to tumor boards. This has been our AI board today, and we've discussed a really important topic around breast cancer, precision medicine, and the future of AI, and how that really changes the landscape in that space. Thank you for all the wonderful perspectives that we've had. We started with Jessica, the CMO of Oncoscope-AI. We talked about drug development, how that's changing, how that space is being disrupted by AI for the better, changing the way that clinicians will be able to reduce some of the burden that it comes to when there's decision fatigue around exactly what research is available and how to compartmentalize that and interpret that. We then had a wonderful presentation by Shanice, where we really heard the patient journey, and Shanice's passion shone through, really embedded the actual use case that we always have to remember when we're treating patients, and that precision-based approach, particularly in culturally challenging treatment areas such as triple-negative breast cancer, and actually the way that is evolving now with precision medicine and machine learning algorithms that are changing that. We then heard from Mehran around actually the research space and how clinicians are transforming the way they're even conducting research, what the next 5 to 10 years around that looks like. And that was all, the conclusion to that was hearing from Anna and exactly the use case that Oncoscope-AI provides, and ultimately the tools that are now becoming available to us for free, and potentially changing the way that we're able to treat patients and transform the landscape. So thank you to all the panelists. I really enjoyed that. I look forward to picking up the conversation.
And thank you to the audience and to you, Oncology. Thank
Pleasure.
you.
And sorry again if I didn't manage to see all your questions, but we will, as Jose said, pick them up. And sometimes they even form the threads of what becomes the next webinar. So do keep them coming. We love a good conversation, a good discussion.
Take care, everybody. Goodbye.
Bye.
Bye.